nandiyan ako, sir? Sir? Nag-start recording ka na?
Recording.
Good evening, everyone. I am Dr. Romero. So I'm here to present a case to you. And as we go along, I wait lang si Sir Sid nag-text pa message naman ng ID. As we go along, please bear with us. This is the first time we're gonna do this case format. So this is somehow an actual case. This is a 48-year-old female who came at the ER due to right flank pain. So the history of present illness, this patient presented with the right colicky flank pain, 6/10 with no other accompanying symptoms. There was no fever at this time and no other associated symptoms. Eventually, this patient consulted at an emergency room where an X-ray was done and revealed they were considering a renal stone. Then eventually, she's also a known case of nephrolithiasis for 10 years. So during this time, once you see this patient presenting with renal colic, what do you think? What can you give this patient to relieve the pain? So the management of pain, NSAIDs are usually the first line unless contraindicated, such as with chronic heart failure, CVD, and also antispasmodics are adjuncts but not as efficacious in pain control, and also opioids as second-line treatment. And for pain refractory to analgesic, an active stone removal is indicated. So with that being said, what are our evidences? So according to our EAU guidelines, as I've said before, you can offer NSAID as a primary treatment, and then secondary opiates such as morphine or Tavadol as the second choice, and then offer for refractory pain or pain that cannot be relieved by medications, an active stone removal such as surgery, endoscopic stone removal is already warranted. So during this time, knowing that the patient has high likely to have symptoms of nephrolithiasis or possibly an obstructing stone, what would you request during this time? So our evidence would suggest that immediate imaging is indicated once the patient is symptomatic with fever or solitary kidneys, and also when diagnosis is doubtful. The modality of choice is a non-contrast enhanced CT scan to confirm the stone diagnosis in patients with acute lung pain following the initial ultrasound. But according to evidences, we may forego the initial ultrasound, although it's still the best. However, not gold standard in evaluating for stone due to its availability and reliability in usage. But as I've said, CT scan is still non-contrast CT scan is the preferred modality of choice. Although ultrasound is can be done. This is a strong evidence. So going back, eventually a CT scan was done. So a CT scan was done, showed a staghorn calculus at the right kidney. So this is the representative images. This is the coronal view, and this is the axial view. So how about for AUA guidelines? So the AUA guideline supports the EAU guidelines that the clinician should obtain a non-contrast CT scan enhanced on patients prior to performing PCNL. So for this, they categorize the AUA guidelines as surgical guidelines for urolithiasis, and the medical is also different. So it would tell you it would also tell you your modality of your treatment of choice. So what kind of surgery are you using? And for this is also level grade 3, clinicians may obtain functional imaging such as DTP or MAG3 if you're considering loss of renal function. So eventually the patient was given celecoxib 400 mg tab and was advised surgery. So the physical examination was unremarkable during this time. So the admitting impression was a staghorn calculi at the right. So for this patient, what additional tests would you request? So obviously you do at the ER, you do the basic laboratory exam. But what are our recommendations? So for low risk or for first-time stone formers, a history, a blood chemistry, urinalysis, urine pH, and stone analysis is advised. For high-risk stone formers, a more detailed investigation is warranted, such as family history, intestinal disease, fractures, osteoporosis, if the patient has solitary kidney. Infirm patients, anatomic abnormalities, renal insufficiency, UTI, gout, pediatric patients, and metabolic disorders. So what does the EAU guideline says? So most of these are weak evidence. The strong evidence for this, when you're dealing with a urethritis patient, is to perform a coagulation test and perform stone analysis in first-time stone formers using X-ray or diffraction and infrared spectroscopy. Also, you repeat strong analysis in patients with recurrent stones despite drug therapy, early recurrence after complete stone clearance, and late recurrence after long stone-free period because of stone composition may change. So this is the rating is strong. So you would usually cater for the patient, but us usually we go with the basic hematology, chemistry, and urinalysis and imaging exam. So how about the AUA? So for the AUA, they require to obtain a urinalysis prior to intervention. In patient with clinical or laboratory signs of infection, urine culture should be obtained, and a CBC platelet count on patients undergoing procedure where there's a significant risk of hemorrhage, or for patients with symptoms suggesting hematuria. So before anything else, you usually go with your basic ABC. So why did I say that? Because you have to rule out if the patient is septic or anuric. So initially, that's when you see a patient in the ER, although not like this, because this patient presented with stable and minimal symptoms, but some of the patients that has some urolized patient would present with shock due to hemorrhage, or most likely sometimes due to sepsis. So aside, these are just guidelines which would be guide for you. But as a basic clinician, you should be able to identify if the patient is septic, because everything won't matter if you don't rule that out. So here are the laboratory results. As I've said, you rule out sepsis. So this one, the urinalysis was unremarkable, and the WBC count was also unremarkable. So what's your operative plan for this patient, knowing CT scan of that in nature? So according to our EAU guidelines, this is what they're using for Campbell also. So they categorize the kidney stone as kidney stone and kidney stones at the lower pole, and by size by 20 millimeters, 10 to 20 millimeters, and less than 20 millimeters. So our CT scan finding was a stone more than 2 cm and a Hounsfield of more than 1,000. It is a Staghorn calculus, so obviously would fall for the category under more than 20 millimeters. So number one, primary is always PCNL, and other options is RIS, same level with shockwave lithotripsy, but it's not. PCNL is this is the primary choice. So it is the first line treatment for larger stones more than 2 cm. So this is a strong recommendation. So how about the others? Treat larger stone more than 2 cm with flexible uteroscopy or SWL in cases where PCNL is not an option. Later, I'll tell you the contraindication for this. In such instances, there are higher risks that follow-up procedure and placement of ureteral stent may be needed. So memorize that this graph, because basically, when I see my patient at the OPD of the ER, at the back of my head, ito yung pumapasok sa akin. So given the other factors, such as Hounsfield units, because in the EAU guidelines, there's only one measure there's only one mention of the Hounsfield units, as you can see here. But it will just say evaluate the stone composition before deciding what method of removal. So yung stone density will likely be disintegrated by shockwave. But as we've seen in the clinics, there are small stones which are very hard. So a PCNL is not always warranted for them. but still considered an active management. So for the AUA guidelines, how about AUA guidelines? So same, a stone burden more than 20 millimeters. PCNL is still they're still offering the first therapy as first line. So and shockwave should not be offered. This is a moderate recommendation. So for clinicians may perform nephrectomy also when the involved kidney has negligible function in patients requiring treatment. So for patients with symptomatic flank pain, non-obstructing calycial stones with another obvious etiology for pain, we will also offer stone treatment. So this is under the surgical guidelines for ureteritis again. So this is the only guidelines for 2019, although this was updated 2016. But wala siyang nagbago since 2019. So this one, I also like to memorize this slide. So I know this slide. So when you see a patient, especially with a nephrolithiasis inferior pole, so when you talk to the patient, they would ask for a medical management. You can mention this. So they would understand why they need the surgery, because here are the chances of a stone passage. So just memorize this at the back of your head, especially pag nasa ureter. So the AUA guidelines prior to surgery, an antimicrobial prophylaxis should be administered prior to stone intervention based primarily on urine culture test. So most of our readings during our residency, they would require urine culture, or if the patient is symptomatic. So we go about our antibiotics based on our urine culture. The clinician should abort stone removal procedures, establish appropriate drainage, continued antibiotic therapy, and obtain a urine culture if purulent urine is encouraged. So as you can see, like us, we're a bit conservative with this. Pag nana yung lumabas, sometimes we defer the procedure. But these are just guidelines. We've seen doctors go with the surgery. If you're trained and you're fast with your learning curve is you're already above your learning curve. So this is a Campbell guidelines. Although again, it's just a guideline. They base this on the CDC. So for PCNL or percutaneous renal surgery, you need antibiotics, preoperative antibiotics. Although I've been in neurology for 4 years, I've known that the first line is always first or second gen cephalosporin, aminoglycoside, metronidazole, or clindamycin. Although most of your readings today, this might not be true as of time. So second line therapy, according to Campbell, is still to amoxiclav or amoxicillin and sulbactam, fluoroquinolone. So probably for examination purposes. But strictly speaking, you don't have to follow this. So what was the operation plan for this patient? So operative plan was a supine percutaneous PCNL at the right. So I'll go with the technical details. So standard stone burden for more than 2 cm. So second option for failed ESWL and unfavorable factors for ESWL, such as inferior pole stones. So what are the contraindications? These are the contraindications as mentioned by Campbell. So uncontrolled UTI and bleeding diathesis, tumor in the presumptive case of the tract area, and potential malignancy of the tumor. So all that we talked about earlier on the preoperative management should be dapat at that time malaman mo na kung may contraindication. And also pregnancy. Although in the advent of, as we all know, in the advent of modern medicine, PCNL can be done under regional anesthesia and positions that are favorable for PCNL. So that probably changes eventually. Preoperative preparation. So we already talked about this. Most of our readings would require a retrograde parallelogram prior to PCNL, as we've done in the past. But as you guys know, we've done a lot of PCNL without an RGP due to that we are using the ultrasound technology. So we're not, we're already past that. But for us, I initially still like to do an initial retrograde parallelogram prior to surgery. And also anticoagulants depending on what. So what are the technical issues on doing PCNL? So previously it was we're doing prone, now we're doing supine. So there's no evidence of which is superior to the other. The only thing superior about supine is the operative time. But this would depend on surgeon experience. But as you've observed with me, I personally prefer the supine technique due to I have more time to do more cases in one day. So other times, the access is also an important part. So upper pole versus lower pole access, the bullseye versus triangulation technique. Excuse me. So dilatation, you might have a personal preference. Personally, I like the telescopic dilatation, but I like the 30 degrees for serial dilatation. And obviously, I don't have the balloon, but it's also convenient to use. How about the energy sources? So what we use is a pneumatic and versus an ultrasonic. We've never done YAG laser, but it can also be done. Some would do an manual extraction. It's also in the books. Manual extraction is using a stone basket or a grasper. So what are the roles of stents and nephrostomy tube? So this is, we can go to the guidelines with regard to stents and nephrostomy tube. So again, guidelines are just guidelines. So as later na skip ko yung ano, I'll go back later than sa stents and nephrostomy tube after we've done this. So for the guys, so usually when you watch me map out, sometimes I'll teach you. So this is the supine PCNL landmarks. If you read the PCNL books on prone PCNL, the landmarks are basically also the same. It's just that the patient is in prone position. So the prone position, I think I deleted the slide. So there's a pad on your pelvis and your chest. So in the prone position, same landmarks: the anterior axillary line, the iliac crest inferiorly, and the 11th and 12th rib superiorly. Your lumbar muscle inferiorly, and then you draw a line in between 2 cm above. Of course, this would depend on the body habitus of your patient. As you can see, this patient, he's he's morbidly obese. So what are our guidelines? So in patients undergoing uncomplicated PCNL who are presumed stone-free, placement of a nephrostomy tube is optional. So it is optional actually, but you have hospital protocols to follow and your surgeon's comfort. It wouldn't hurt if you put a nephrostomy tube. So a flexible nephroscopy should be a routine part of your standard PCNL. As you've noticed, after we remove all the stones, we check out all the calyces before leaving. Or we check, usually the last I check is the pelvis. Why? Because most of the stones, due to gravity, the residual stones would lodge there. And this could be problematic once you close the patient. So some books would prefer a stent. So remember, tubeless without NT, totally tubeless without NT and stent. Okay, so clinicians must use normal saline irrigation for PCNL and URS. Okay, so the operative day, so we found a 2x3 staghorn calculus at the right side of the kidney. So before anything else, if you do your operation, so you have to be able to know how to manage your complications, because complications are part of surgery. So usually, in general, 10% is an accepted complication. So what are your complications during PCNL that we may encounter? So first, this is in Campbell. So a collecting system perforation is the first sign, a narrow pulse pressure, hypercardia, or hypertension. So with any complication, you should be able to know how to manage it. So for a minor perforation, you may continue. Just apply low pressure system. Apply low pressure to prevent the collecting system from tearing apart. So you can use your amplats to avoid further manipulation. And also for major perforation, you just terminate your procedure and decompress the system. Because usually perforation of the collecting system would warrant an extravasation of your saline and sometimes the stone also. So how about for intracellular absorption of fluid? So I've seen surgeons that diurese every 30 minutes. Every 30 minutes for every 30 liters of fluid. So there's no guidelines for this. It's just maybe you can check it's hard to check the urine output, but your anesthesia usually check the vital signs. For bleeding, usually venous in nature, depends on the extent of bleeding. So persistence and hemodynamic stability. So what you can do is cover the blood loss, and you can use a tamponade. So there's such thing as a nephrostomy tamponade balloon. So you can put a balloon, and the track would tamponade itself. But usually an amplatz is enough, in my experience, by proper manipulating and locating where the bleeding is. Usually visibly, if you've seen enough, you'd know where the bleeding comes from, and you know where to put your amplatz and to tamponade it. In some severe cases, you can do partial nephrectomy, but I haven't read anybody or any evidence for that. Next is a colonic perforation. This is also common for 10% of 10% may have 1 to 10% may have colorectal colonic perforation due to a retroperitoneal large bowel, but this is less. So what's the how to avoid this? So you have to check your CT scan in all views. So usually you've seen, I'm sure you know how to locate the bowel. So we do it every time we do our PCNL. I do it with you at the ORs to know where we should access. So what do we do? So if the patient is stable, you just put an NT in the colon and put a stent, then reassess for 7 to 10 days. So the third line is explore with peritoneal signs. What does this mean? So you actively monitor you do serial abdominal examination. If there are peritoneal signs, it is advised you open the patient. So next is an AV fistula. I've seen 3 patients with AV fistula. So what we can do is bed rest initially. So sometimes it is not enough for bed rest. Some cases, after 2 weeks to 1 month after your PCNL, an AV fistula, your patient would present with a vermiform blood clot in the IFC. So the best thing for this patient, the best option for this patient is to refer to your friendly interventional radiologist to do an angioembolization. But I've seen patients underwent nephrectomy due to an AV fistula. I've also seen a patient who underwent conservative management. So it was stabilized after 2 months because they cannot afford an angioembolization. So for next is the pulmonary complication, same as any other complication. So you usually do a CTT or needling, and if the pneumothorax is less than 10%, you can observe. And of course, sepsis is managed accordingly. So as you've noticed, although it's not written, what we do is we give gentamicin prior. So it's part of our preoperative plan to prepare a gentamicin. So we give gentamicin depending on the renal dose, 80 or 160, 30 minutes prior to stone breakage. It haven't failed us recently. So that's the best for me, ever since our time with my chief resident before. So this is the initial RGP of the patient. So on your left, there's already a contrast. On the right side, so this is post-PCNL. So stone-free yung patient natin. So we were able to evacuate all the stones. Now, how do we follow up this patient? So what initially would you tell? So of course, when do you retain your nephrostomy? And when do you retain your DJ stent? So personally, it would depend. Personally, what I do is I do an initial tamponade from 2 to 6 hours, and then open the drainage to discharge. But some of especially if medyo suspicious ka sa stone, it looks infectious, it's a big stone, it's a staghorn, so you open all the way. But sometimes, laging sinasabi sa atin, what's the purpose of your drain? Sometimes if your purpose is just to tamponade, you can reclamp again. And then once it's clamped 24 hours, there's no complaint, you may remove it right away. And how do you position your patient? Usually, the opening is gravity dependent. So it's best to put them against gravity or on a lateral position. So 24 to 48 hours, you may remove the drain. Unless you're planning on reoperation. So you can do you can do PCNL with the same access. So what are the general recommendations? It's recommended a fluid intake of 3 liters a day, urine output of 2.5. The carbonated and citrates are assistive or protective. For phosphoric acid in keystone risks, protein restriction, sodium, moderate calcium level, limit vitamin C, BMI, and physical exercise. So what can you do? This is already proven, so you don't do metabolic workup initially. So you do it 20 days after the patient is stone-free. So you do a consecutive 24-hour urine collection. You check for the urine composition. Sodium, chloride, potassium, magnesium, so all those. And then you determine the diet under normal conditions. So what we do, sometimes we give them a flyer, but most of the time, we refer them to dietary. So it's already a protocol for the nurses to refer them to dietary for dietary management. So usually low sodium and low purine diet. So what is this diagram? So this is also according to EAU. So for patients with stone, so this is an algorithm. So if the stone analysis is known, you just do the basic analysis that I discussed earlier, the earlier slides. And if it's unknown, you investigate. How? You determine if it's a low-risk stone former or a high-risk stone former. So if it's a low-risk, what I've said earlier during the slides, just the basics, yung PTPA, and the basic urinalysis and CBC. For high-risk stone formers, and sabi ko kanina, 24-hour urine. So you do a metabolic workup. So this is just a summary of what I've said. This is really important, usually for children or those who are on the special population, the diabetics. Yeah. So what would you advise this patient? So what does our guideline say? So our guideline say remember, it's not the fluid intake. It's just a generous fluid intake. It's usually the urine output. So you make them measure the urine output. It should be more than 2.5 liters. So I've heard people saying the intake. It's actually the output. So this is our operative impression. Sorry, that's ano pala yun? C-arm guided. So let's go with the elephant in the room. Of course, in the time of COVID, what could have we done? So this is just a reiteration of what we've listened, of what we've heard earlier this morning. So what do we do? I personally lifted the EAU guidelines, so because I think it's more detailed. On the PUA, it's not. The PUA also gave a guideline, but it's not technically a guideline because they just mentioned what you can do and what you can't do. So it's more solely focused on the urgent and emergent procedures that you can do, and the basic office procedures such as prostate biopsy. But no mention of urolithiasis actually. It's more oncologic. So you have to know the definition. So what category your patient will fall into. So, dalawa yan, diagnosis and treatment. So, low priority, memorize na lang. Clinical harm, unlikely if postponed for 6 months. So, in common sense, we can postpone for 6 months. Immediate, clinical harm possible if postponed 3 to 4 months, but unlikely. And high priority, nag-fall din dito yung cancers. So, very brief lang to. Clinical harm, very likely if postponed for 6 weeks, and emergent, life-threatening, so emergency. So where does our patient fall into? So our patient may fall into suspected asymptomatic renal stone. This is a known patient na kasi. So what do we do? We do imaging. So luckily our patient already had an imaging, so we can skip this. Next, this is ito yung medyo important. So I said you have to rule out initially sepsis. Why? Because sepsis due to an obstructing stone would warrant emergency, urgent decompression for the collecting system. So on our patient, this is a renal stone causing intermittent obstruction. So there's a mild dilatation. So what do? We do stone removal or an active removal, or JJ stone, double J stone, double J stent placement. So it would depend on your hospital protocol. So in our setting, alam niyo naman. So luckily, we can do our nephrostomy tube insertion as outpatient basis. But most of the time, if you have this at the back of your mind, if you see a patient at the ER, alam nyo na agad what active management can you prefer. So I'm sure you're getting phone calls from the RTB patients too. So that's it for my lecture. So if you have any questions, please just turn on your mic.
Yes, sir. Yung part kasi na actually I'm more of okay naman comprehensive naman yung lecture. But I'm leaning towards the part yung technicalities of the PCNL talaga. So that is actually the purpose of this. More of yung what we discuss is management of urolithiasis. So
Yes, sir.
punta ka doon sa technicals ng PCNL. Ayan. Yung technical issues. These are the things that I want you to discuss actually. So parang with regards to access, how do you access, yung mga ganun. Yung sa very operative na procedure. Parang kung ano yung step by step. Parang kumbaga yung OR technique. How would you go about it? For example, sa how do you access? Ano difference ba ng bullseye versus triangulation? So how would you explain it to your residents?
Okay.
Maybe just add it next time. So basically yung isa sa mga kasi parang this kasi is more of you are teaching them how to operate also. Kasi since we are not doing any operation right now, that's the purpose. Parang tinuturuan mo sila in a didactic form. Parang pero okay naman, maganda, comprehensive. But yun nga, maybe a little more data regarding this technical issues.
Okay. Anyway, this is the first time we've done this naman. So next time we'd be more, we'll focus more on the operative techniques such as this. Maybe show some pictures also how to basically do the procedure. So siguro just the basics of it. Anyway, this is commonly done procedure. So again, the positioning, you know that, and then the access. This is somehow differ. So why? Because sometimes, most of the time, remember when we were doing prone, we always use bullseye and triangulation. But nung nag-supine tayo, we're always using triangulation. So that's just the gist of it. But I remember doing bullseye technique. It's much more, for me personally, it's faster. But sometimes, literal, it's like hitting a bullseye. If you don't hit it, you miss everything. So you should learn both for this. And yun na, yung upper and lower pole access. An upper pole access is also really good in locating all the calyces. Ito yung before, when I was learning supine PCNL, hindi ko ma-perfect yung visualization of all calyces due to the limitation of position. But of course, if you've done enough, you may do upper pole access in a supine position. And the dilatation doesn't differ. We've done all these. For me lang, advise doing the telescopic. So I'll do a brief background for the serial. So serial dilators are Alkene, or Alkene is the brand, Alkene dilators. So every time you dilate, you take out the dilator. So it's a long process. You move by twos of French's of twos. So I start usually with 8, 10, 11, 12 until I reach the size of my amplats. The amplats in our hospital is 27. So after 26, you may remove the final dilator. Although our dilator may go up to 30, but sometimes the bigger you dilate, the more perfuse your bleeding is. So I prefer telescopic technique kasi medyo, syempre, I'm more used to that. And then for the energy sources, it would depend on the stone composition. Sometimes stone is not that quite hard, usually 800 to 1,000 Hounsfield units. It's nice to use an ultrasonic technique. It's just breaks your stone and sucks it out of the collecting system. However, most of Filipino patients, they have hard stone. So for me, pneumatic is the best. You can just fragment the stone and then just manually extract it using the grasper. I haven't done stone basket extraction at the collecting system, but sometimes I've seen one surgeon do it using a basket, actually si Dong yun. And then usually you know the purpose of your nephrostomy tube. So basically that's the technical issues. You can see lots of our videos doing this. Do you have any more questions regarding the techniques? Hello?
Open mic, open mic.
Any comments on things like this? So
Hello. Happy birthday, Dr. Panganiban.
Dr. Pangiban, happy birthday po.
Happy birthday, Mike!
Unmute.
Hindi nakamute si Mike.
Happy birthday, sir. Happy birthday, Dr.
Birthday.
Panganiban. Smile naman daw, Mike. Smile.
So,
Anyway, yun. Hello. Anyway, yung ano nga, basta yung susunod siguro na lecture, focus more on the operative technique. Yun nga, yung mga technicalities. Okay yung ginawa mo, binilagay mo lahat ng mga tama naman yun yung pinag-usapan natin. Mula pre-operative screening, patient selection, lahat hanggang sa post-op care. Okay siya. Yun lang siguro, yung content dun sa OR technique. So, marami actually pang madidiscuss tungkol sa PCNL. Especially dun sa part na yun. Regards sa supine, sa prone. Meron pa nga iba may lateral pa yan. Tapos sa supine, ang dami-daming klase sa supine. Tapos, yung dun sa access, may superior, may upper pull, and regarding sa pag-access mo, kailangan ba dun sa infundibulum talaga? Yung mga ganon. Those are the things that I was expecting. Pero okay din naman. Tapos yung yung technique ng pag-access, yung bullseye, triangulation. So pwede mo kasing ituro sa kanila through imaging, through the yung mga drawing, ano yung position ng C-arm, paano mo siya gagawin. So this is how you will teach your younger residents for that. Then, basically yun. So next time, ano ba yung topic natin na procedure yung susunod?
Our topics are Ano, sir?
Hindi, yung pag Friday.
So, Friday, sir. Unilateral reconstructions, sir. Mga buwari flap.
Yun. So, more of technique talaga. Kasi, di ba, na-mention na ni Ernest last, yung mga indication. So, with regards to that, more of technique, yung mga ilang CM ba talaga dapat, paano mo siya gagawin non-refluxing, ano ba yung mga non-refluxing. More of yung technique talaga. Most of which can be found in Hinman also. Even the old ones, try to look for the old edition ng Hinman para mas detailed. Kasi ngayon puro
Carl?
Yes, sir. Yun, happy birthday, sir.
May question lang, President.
Okay.
Happy birthday!
Question lang. Thank you. May tanong ako sa residents. Na-mention kasi ni Rom kanina, before you do the procedure, culture studies, tapos load antibiotics for the patient. Pag septic, you don't do the procedure. Right? Rom?
Yes, sir. Yes,
okay. So, during M&M, maraming na-present na case, septic pa rin yung pasyente despite culture-guided antibiotics. Gusto ko i-drive to sa inyo what could have caused that septic patient. Sometimes they expire and anong iniisip mo doon?
Usually, sir, the bottom line for sepsis in patients undergoing PCNL is the high pressure in the collecting system. So, ideally, it shouldn't be a closed system. But what happens since if we don't have a diffuser for the amplats, there's high pressure collecting in, and they may absorb. So from the negative pressure, it would the systemic circulation may absorb that irrigation with the microbes from the stone. So that basically is the logic for having sepsis for PCNL on undergoing PCNL.
So your answer is technique. Whether high pressure, low pressure, closed
No.
system, or yung length of OR, yun yung pinupus mo.
Yes, sir.
Okay. So what I'm driving at is more of on infection. Even though you're covering
yes.
for everything. I know you know this, but the juniors don't. So I think you failed to mention this. What would be the primary consideration a patient post PCNL, short operative time, but still goes into septic shock?
The stone breakage, sir. Although you may have a sterile environment in for blood test prior to, ideally a blood test and a urine culture or a blood culture. So even though you have a sterile surroundings, once you break the stones, that's the time that the microbes would be absorbed. But so it doesn't mean that you have a negative culture, you have a sterile environment. Sir.
Aside, what particularly sa microbes ang nagko-cause? Sorry.
Depends, sir. But if it's infectious, usually the infectious type, it would survive in a basic surrounding. So usually an E. coli is possible. And also, if it's a staghorn calculi naman, so you have our infectious stones for that. So
okay.
madaming
So,
multifactorial.
One of the factors dun sa multifactorial would be toxins.
Sorry, sir. Protein,
So,
sir.
Yeah. During the procedure, the release of the toxins that would lead to yung septic shock.
Toxins. Yeah.
Ha?
Yes, sir.
Toxins, right? Na literally wala namang gamot sa toxins. Right? So, hello?
Endotoxins, Roma. Endotoxins.
Yan, endotoxins.
Informed endotoxins.
Walang treatment nga doon. Kaya nga, yun yung, aside from yung, kahit naka-cover ka antibiotics, you still have to put that in the back of your head during the procedure. Right?
Yes, sir.
Baka, mismo lang yung, I'm sure yung mga yung junior residents, yun ang straight point out.
Endotoxin.
Endotoxins, correct.
Yes, sir.
Thank you.
Thank you, sir.
Attendance?
Rome, ilang percent na yung culture mo na binigyan ng antibiotic will matter na ba't nag-sepsis pa rin yung pasyente? Do you have a percentage? No.
No, sir.
Ilang percent ang nag-sepsis daan sa mga pasyente na naka-culture guided na ang treatment prior to surgery?
From what I remember, sir, a negative culture may 30% yun, sir. But morbidity, sir, 30%. But the mortality rate is less than 1%, sir.
Yeah. Magkakaroon ka pa rin ng sepsis, impossible pa rin na mortality. No?
30%.
So, yeah, 25 to 30% actually ang discrepancy yan. Sterile urine kasi pwedeng obstructed, kaya hindi bumababa yung urine on that system. No? Kaya hindi bumababa yung mikrobyo.
Yes, sir. Thank you, sir.
Happy birthday, Mike.
Thank you. Thank you. Maraming salamat sa bate.
So we'll just take a picture for the logbook, sir. We'll take a screenshot for the logbook.
Nasa hospital pa si Boss Ermi, ah.
Happy birthday.
Sa bahay na yan.
Meron na poster sa likod, eh.
DIY clinic.
Yeah.
DIY clinic yan. Di ba?
Ayos yan. Approve.
Ayoko na. Alright. Thank you.
Sir.
Thank you, thank you.
Hey, thank you. Happy birthday, Mike.
Happy birthday, sir.
Thank you. Alright,
Happy birthday.
Ingat kayo.
Lenny,
Thank you, sir. Happy birthday.
Good job.
Maliwanag na ngayon, eh.
Sige.
Sino next lecturer natin?
Sir Sid, sir. Sir Sid.
Sid. Kung pala next lecturer, eh. Sa Wednesday ba yan?
Wow. Matatawag niyo pa si Sid, ha?
Infections, sir. Infections. Urologic infections.
STD.
Tama-tama, sir. Nasa Angeles daw kasi siya, eh.
Duty.
Pag nasa Angeles.
Walang pasyente dun, sir, eh.
Sir, pa-vote na lang ng poll kung anong gusto niyong platform.
Meron na tayo na.
Sid, kamusta na na-discharge na ba si Bong Pineda?
Hindi sir, nasa ward na sir, tapos stable.